Good morning, everyone. Thank you for being here this morning, and welcome to our first Breakthrough Breakfast of the new year. I'm David Anderson. I'm the Dean of the Faculty of Medicine at Dalhousie University, and it's a pleasure to be here to host you here this morning as we explore a very timely topic, family medicine research. Before we begin, I want to acknowledge that Dalhousie Medical School and Pier 21 sit on the ancestral, unceded, and unsurrendered territory of the Mi'kmaq Nation. As peace and friendship treaty beneficiaries, we have a responsibility to continuously educate ourselves and work in solidarity with the Mi'kmaq and other Indigenous communities. We also recognize the histories, contributions, and legacies of African Nova Scotian people who have been in these lands for over 400 years. So thank you again for joining us today. It's wonderful to see so many people here at our Breakthrough Breakfast, our quarterly series which showcases Dalhousie researchers who are changing health outcomes in our region and in our country. So this is just the prompt intro here, words of welcome. I want you to enjoy your breakfast and conversation. Our program is going to start in about 10 minutes time, and please feel free to enjoy your breakfast throughout the presentations this morning. I'll see you in a few minutes. Morning again, everyone. I hope you're enjoying your breakfast and your conversation this morning. And again, we are going to have regular presentations here for the next few minutes. And please continue to eat throughout the festivities. Everyone is expecting it, and we want to make sure you enjoy that this morning. So today, we're really excited to have 4 Dalhousie researchers presenting their work in an area that is top of mind for Atlantic Canadians, family medicine. They will be presenting in a TED Talk format. You'll hear from each of our researchers for about 8 minutes. And at the end, we're going to bring all of our researchers back to the stage, and our Executive Director of Advancement, Ms. Catherine Ewell, will be hosting a question and answer session, taking questions from you in the audience. And we promise we'll be wrapped up by 9 a.m. to allow you to move on with your busy days. I want a special thanks and shout out to our sponsors who have made this event possible. Our gold sponsor is Shanex, a family-owned organization with a vision of leading the way to a better living. And our bronze sponsors are the QE2 Foundation, Lawtons, and the New Brunswick Medical Society. So if I could ask for a short round of applause for our sponsors here today. Their support is crucial in allowing us to share critical, homegrown medical research with our community. Although primary care is the cornerstone of our healthcare system, it faces some substantive challenges, in part due to shortages of family physicians in our region and indeed in our country. I'm pleased that there is reason for optimism as collaboration between governments, our provincial health authorities, universities, physicians, and community organization are driving improvement in primary care. In the Maritime provinces, there are increasing investments by governments in creating and recruiting physicians, nurses, and other health professionals to work in the primary care space. Please indulge me in a little bit of bragging about our own Department of Family Medicine at Dalhousie. Initiatives like the Cape Breton Medical Campus, launching later this year in collaboration with Cape Breton University, will be training 30 family medicine graduates annually. Thanks in large part to our Department of Family Medicine, which provides excellent educational experiences and mentorship for our medical students, over 50% of Dalhousie's graduating class in 2024 chose to pursue careers in family medicine. This is a number far surpassing the national average of 30% at other Canadian medical schools. We've also seen a rapid growth in the number of residency positions in our Dalhousie Family Medicine Residency Program, increasing from 54 in 2018 to over 90 in 2024, with a planned expansion to over 150 positions by 2030 with the graduation of students from our Cape Breton Medical Campus. This remarkable commitment to family medicine, supported by our provincial governments and provincial health authorities, will help ensure that Maritimers will have a much greater access to primary care practitioners involved in team-based care in the very near future. In addition to training excellent family physicians, our Department of Family Medicine leads important research in this field. So let's get on with this morning's program. Today, we're fortunate to have a panel of leading researchers who are driving meaningful change in family medicine. I'd like to invite our first speaker to the stage. Dr. Emily Marshall is a professor in our Department of Family Medicine and an affiliated scientist with Nova Scotia Health. Dr. Marshall's work focuses on improving equity and optimizing outcomes in primary care, with particular attention to equity-deserving populations. Dr. Marshall, thank you very much.
The clicker. Good morning. We've been anticipating this and are very excited to be sharing some work in primary care with you today. By show of hands, how many of you know someone or is currently struggling to find access to a primary care provider? Oh, wow. So we're on topic. So I'm Professor Emily Gard-Marshall. I joined the Department of Family Medicine back in 2015. So I am that old. That's where I lead research, and I'm the director of BRIC Nova Scotia, which is our strategy for patient-oriented research network. When I joined DAO, I was coping with an undiagnosed and a health issue, and I was unable to actually find a family doctor at that time. And I was told that we had the most doctors per capita in Nova Scotia, so it didn't make a lot of sense to me. I started cold calling primary care offices to no avail, and I found it to be a very demoralizing experience, which it sounds like many of you may have also experienced. I started cold calling offices. I finally secured a family doctor 3 years later who referred me. I saw a specialist within 4 months, and I had surgery 2 days later. But why was it so difficult to find a family doctor way back in 2015? So in 2015, 4 out of every 2 visits to healthcare visits were to primary care in Nova Scotia, with a much smaller number of visits to emergency departments, surgeries, and hospital admissions. So primary care is indeed primary. Probably not something I need to sell to this audience. Primary care providers can include family physicians who work in fee-for-service models or salaried collaborative care teams. They can include registered practitioners, registered nurses, dietitians, physiotherapists, community pharmacists, and so on. Despite having various primary care options, there's not enough. Many Nova Scotians struggle without access to a provider or a team who knows them. The growing concern led to my MAP and PUPPY studies to understand why we're struggling with primary care. As of January 2025, 110,000 Nova Scotians are currently waiting for a primary care provider. Why? Well, part of it is population growth and that continues to rise. We've seen large numbers of providers, retirements, especially through the pandemic, and Nova Scotia already has fewer family doctors than the national average. A large aging population and federal transfers that don't actually account for the age of our population are also part of the equation. So what are the consequences of unattachment? I led a study called the UP study for unattached patients around their experiences of being unattached. You can see from this slide that there were a number of things that people talked about. They talked about the care burden of not having access to a primary care provider, the lost care that they had, and then the different health impacts. There was one that was sort of positive. Some people said, well, I made lifestyle changes so I wouldn't be so sick and have to see a doctor, which is great, but probably not the ideal solution to getting access to primary care. And overall, they described having really strong feelings of stress and anxiety and concern about the future when they actually might need more care, and where were they going to get that. So what are some of the potential solutions to support unattached patients? Some ideas that we've tried include short-term access to primary care clinics and virtual care in Nova Scotia, incentives to primary care to increase the number of people they see, incentives on spending to hire and attract more primary care providers, and providers working to the top scope of their practice. But before we go any further, we should ask, what are we aiming for in primary care? This is a wicked problem. Simple improvements to one element can have unintended negative consequences on others. So research often uses models to help us identify those elements of a problem, and I adapted the quadruple aim from Bodenheimer to try and look at equity and access. So let's look at these quadrants. We want to overall improve the population health outcomes in an equitable way, so people who need the most get access quicker. We want to optimize costs generally for the population. We want better patient experiences and equitable access to care. And we want to improve the care team and well-being work life of our providers as well. I didn't forget you. So Nova Scotia has tried to incentivize primary care providers to take on more patients with bonuses in 2018, bonuses in 2020, and bonuses in 2023. But our paper, A Band-Aid Solution, described that while there was some uptake and attachment and compensation for the onboarding time, it did not address the burden on providers nor the provider shortage. So wait times increased because providers were already at or over capacity, and adding more patients was contributing to more primary care provider burnout. And this exemplifies the wicked problem we're dealing with. So what if we tried to spend our way out of this problem? Can we just hire more primary care providers? We underfund primary care in Canada compared to other OECD countries. Canada ranks 17th in primary healthcare spending, with room to grow in providing primary care funding for general care and prevention. But available providers are hard to find. Training programs are adding more spaces, but it's going to take time to catch up with the needs of the population. And this is also a global problem. There are challenges of recruitment in all countries. So as primary care continues to cope with a deficit, our best strategy is to train and get as many healthcare providers to work to their full scope of practice with adequate systems of support, including timely referrals to diagnostics and specialists for their patients. And additional strategies include developing new roles in primary care, such as the physician assistant program that's now going on at Dalhousie. More collaborative care models with allied healthcare professionals working to their full scope of practice within communities are supported from evidence from my MAP and PUPPY studies, identifying positive impacts for collaborative models. I also want to give a shout out to the new Mentor Clinic led by Dr. John Ross. This is a demonstration of an allied health professional collaboration, sort of similar to what we do at Dal Family Medicine as well. My own personal experience with this clinic has been outstanding, and I believe it's great for primary care in Nova Scotia to support the quadruple aim. So it sort of addresses all of those quadrants by bringing together a large team. And another important, another network improving the health and quality for life in Nova Scotia is the primary care providers, Nova Scotia, their primary care providers is the BRIC Nova Scotia Network. So this is the Building Research for Integrated Primary Care. This network offers a primary care research day, student seminars, brewing ideas, letters of support, and a new primary care patient advisory that we're developing now. So if you're interested, please get involved. Always looking for speakers. And coming to the end, my own family doctor read my paper on wait times for specialist care, forcing doctors to work beyond their scope of practice. It was heartwarming when my doctor thanked me because she felt so heard and understood in her research. She also mentioned she only had time to read it because there was a massive storm and she couldn't go to the office that day. I want to end with incredible gratitude for being able to work and collaborate with the Department of Family Medicine and other partners, including Nova Scotia Health and the Department of Health and Wellness. Nova Scotia and Dalhousie are incredibly wonderful places to do work as a researcher and collaborate with other folks. Family physicians, nurse practitioners, and other allied health professionals are some of the most nice people I've ever met, and it's such a privilege to get to work with those folks on a regular basis, and I just want to thank you for what you do and hope that your advocacy in collaboration with our research will facilitate more access to primary care in the future, and that's it for me, folks. Thank you very much.
Thanks very much, Dr. Marshall. I'd now like to introduce Dr. Ruth Laverne. Dr. Laverne is an associate professor in the Department of Family Medicine and an affiliated scientist with Nova Scotia Health and a Tier 2 Canada Research Chair. She investigates disparities in access to care and how policies like virtual care can improve equity and sustainability in primary care. Dr. Laverne.
Thank you so much. Okay, so when my friends or family ask what my research is about, I usually say I try to answer this question. So if there are more family physicians than ever before, why can't I find one? The problem with this is no one really believes that first part, so I gotta bring the data. So it's true, we have more family doctors per person in Canada now than ever before, and we've always had a little bit more than the average here in Nova Scotia and in New Brunswick. And that surprises a lot of people because it does not feel like it. Add to that, nurse practitioners, pharmacists, lots of team members are playing new roles in primary care, so we have more people involved. But at the same time, we've heard that access is falling overall, and gaps in access are growing wider. So when we look at who has a regular place to go for care, based on your income, whether you own your home, whether you've recently immigrated here, whether you're racialized as white or as non-white, gaps in access exist and are growing wider. So what explains this gap between patients' needs and the primary care services available? My research looks at three main themes. So how population needs for primary care are changing, how the work that primary care clinicians do is changing, and how the systems those clinicians are working in are changing. Let me tell you about all three. So, no surprises, the population is aging and is being treated for more chronic conditions over time. So, folks over 65, that's growing, same with people treated for 3 or more conditions, and it's always been a little bit higher than average in the Maritimes. But over and above aging, more work needs to be done now as part of each primary care visit. So looking back 20 years, your average person over the age of 80 would have had 8 family physician visits, would have spent 5 days in hospital, would have had 6 prescription medications and 10 lab tests. 20 years later, someone over the age of 80 would have had the same number of primary care visits, spent fewer days in hospital, and that's good news for hospitals, but it means we have more work to do in the community. They would have had an extra prescription medication and double the lab tests, so more work is being done per visit. When we look at clinic data, we see the same thing. The number of services that need primary care coordination have increased, so prescriptions, lab tests, referrals, all of that is growing per doctor, per patient, and per day. In addition to this, we have more family doctors, but they're also playing new roles within the health system. So when we look at that increase, a lot of folks are working in emergency departments, coordinating care in hospitals, and those are necessary functions in our health system that we may not have been planning for adequately. On top of that, the system is getting more complicated. If you have tried to access care, you might have experienced the challenges understanding what connects to what and where you go to meet your needs. It also contributes to additional paperwork and administrative work for people working inside of the system. So administrative work is piling up. We hear about this idea of administrative burden, and it's sometimes described as just like unnecessary paperwork. But this doesn't pay attention to the function it serves within health systems and to the impact it has on people working within them. So we interviewed family physicians, nurse practitioners, and other team members. And central to administrative work is paperwork. It's administrative management of information. So filling out forms, doing referrals, making sure that information gets from one place to another. But that's not the whole story. Loaded on top of that is information stewardship, so being responsible for patient confidentiality and making sure only information that should go somewhere gets there. Loaded on top of that is clinical responsibility, that you have to interact with that information and exercise good clinical judgment. And loaded on top of that is moral responsibility, so responsibility for the outcomes of administrative processes and making sure people's needs are met, even if you don't control the process yourself. And that is stressful and wearing folks down. So what do we do about it? I had an awesome student this summer who reviewed the literature on administrative work in primary care. And sure enough, we found drivers like documentation and record keeping, billing and insurance interactions, and solutions like reducing or streamlining these requirements, also technology, and task shifting, so finding someone else who could maybe more appropriately do that work. The problem is, among the drivers, we're also technology and task shifting. Add to this, in the literature, it often focused on doctors and not the people who might actually end up doing that administrative work. And it also had very little attention to patients and caregivers. And I'm sure everyone in this room has spent time coordinating care for yourself or people you care for. We also need to pay attention to the fact that there are people who have to navigate systems that fundamentally were not designed to make them well. If you are Indigenous, if you have disabilities, then you may be trying to do paperwork, trying to navigate processes that through completely legal mechanisms are not designed to support you. That has a word, and it's administrative violence. And so we need to pay attention to the fact that these processes operate on a continuum and impact everyone, but in different ways. So, what has to happen to make sure folks can get the care they need? We've heard that to correspond to population needs, we need teams that are equipped to deal with this complexity. And we've heard about some great models already from Dr. Marshall. But really importantly, a team isn't just like some folks sent out on the field and told to win. We need shared playbooks, we need common processes and goals, and folks need time to train to run in support of each other. To deal with the fact that the workforce is changing, we need proactive workforce planning so that we can not just respond to, but predict how needs change over time. And to deal with changing systems, we need infrastructure that's fit for purpose. So that's not just clinics and medical equipment, that's information systems, and again, that's teams that have administrative capacity as well. So paying attention to the people who are booking your appointments, screening you when you come into a clinic, or organizing the flow of work within a clinic. Okay, so who's in charge of making this happen? Or who's in charge of primary care? I put this up to get a bit of a laugh. But in all sincerity, there are folks working in different pockets of the health system trying to affect needed change. The challenge is there's no one government department of primary care. This responsibility is shared across different parts of the health system that all have to push in the same direction to make change. That's one thing we can help with as researchers, is bringing folks together in a room and making sure those conversations happen. We can also help with solutions. So to conclude, some ongoing work speaks to administrative burden, where we're understanding these experiences, but also bringing folks together to identify practical solutions to address them and figure out who has to have a role to make that happen. We're doing work on new models of care, like Virtual Care Nova Scotia and eVisit New Brunswick, to understand both patient experiences, but how those new models spill over into impacts system-wide. We're also doing work around new models of payment. So Nova Scotia, as well as a number of other provinces, have changed how they pay family doctors. So does that change clinician experiences, recruitment, and retention? And does that change the care patients can access and whether you have access to an ongoing care provider? And then finally, workforce planning. A big focus of mine is pulling together data from across systems so we can monitor these trends and build them into our planning proactively and make sure we are actively planning for equitable access to primary care. If that's of interest, drop me a note. I'm always happy to tell you more about any of those studies, and thank you so much for your time today.
Thanks very much, Dr. Laverne. Next, please welcome Dr. Matthew Grandy to the stage. Dr. Grandy, a Dalhousie Medicine graduate, directs the Maritime Family Practice Research Network. His research leverages data to enhance prescribing practices, manage chronic diseases, and explore AI's role in primary care. Dr. Grandy.
Okay, so thank you. I'm here today to talk about harnessing the power of technology to improve primary care. And to set the stage, I just want to talk a bit about kind of a typical day at the office. And I think most people here have a good sense of what happens when they go in to see a physician, but what I want to talk about is what happens after that patient leaves the room. So the majority of folks these days are now turning after the patient leaves and entering that information into the office's electronic medical record. So they're entering a summary of the encounter, they're entering physical exam findings, blood pressure, they may be renewing medications or sending a referral off to one of our specialist colleagues. And as Dr. Marshall highlighted, this is happening at a high volume across the province on a daily basis. 9,800 kind of visits per day. And you can imagine the volume of data that accumulates over the course of a day, a month, or a year. And so my predecessors saw an opportunity here, and an opportunity to harness that data for use for primary care research. And that manifested as the Maritime Family Practice Research Network, or MARNET. And in its current iteration, MARNET is a collection of 80 family physicians and nurse practitioners who have an interest in research, who contribute de-identified electronic medical record, or EMR data, to a database that is used to answer questions pertaining to primary care in Nova Scotia, but also on a larger scale as a network within a network of networks that spans the country called the Canadian Primary Care Sentinel Surveillance Network. So I want to talk very quickly about EMR data. EMRs were created as a data entry tool. They're an electronic version of a paper chart. And when we try to get that data out to use for research, it looks kind of like this image. It's a mess, it's chaotic, you can't connect one point to the other. Over the course of the last 16 years of the existence of this network, we've worked closely with colleagues in computer science and data science, one of whom is with us today, so Sarah Sabry, who takes this mess of raw data and turns it into something more organized and usable for research. And so to kind of come back to our visit, so up on the screen here we have Mrs. Smith, 78-year-old. She's in to see her family physician, and one of the things she'd like is a medication renewal. And so her medication list looks like this. We won't go through this in too much detail, but she's on medication for diabetes, for blood pressure, some for mood, pain. She's on 10 medications, and she's over 65. So she meets the criteria for something that we call polypharmacy. And what we know about this group is they're vulnerable. They're a vulnerable group. They're a group that's at risk for medication complications, either due to interactions between those medications or the cumulative effect of those medications. We also know that they have increased healthcare costs. So the more medications a patient is on, the more likely they are to be visiting the emergency room or having frequent visits with their primary care clinician. They have an unmet need to some extent. So this is a vulnerable group that is a great target for an intervention. And I want to talk about a project that I've been involved in over the course of the last 6 years, which we refer to as the SPIDER Project. And this project really highlights the power of a practice-based research network. So we use EMR data, and in this project we use it in two different ways. The first way is we created what we call an algorithm, or a way that participating providers can quickly find this at-risk group in their practices, and they can do it in a way that maintains that patient confidentiality. And then we also use that data on the other side to measure the outcome of our intervention. So it's constantly ticking along, but our intervention utilizes this network that we have in Nova Scotia, this group of practices who are interested in being a part of research. And so what we did with this project is we brought practices together. We created what we call a learning collaborative, where we had groups in the intervention who came together virtually and had some didactic sessions around deprescribing of potentially inappropriate medications. We had some sessions around how to run a quality improvement initiative within your primary care practice. And then we had some open forum for discussion between those practices on how things were working, how they were going. And alongside that, we attached a quality improvement coach who followed the practices along for a year and helped them put into place a quality improvement initiative around deprescribing of their choosing. And so, as you can see from the image up here, 3 provinces have completed this intervention. The study's been going for quite a while. COVID got in the way a little bit and slowed some of the provinces down. Nova Scotia is one of the provinces that has completed the intervention, and the early findings from the study show a positive effect. So this intervention has been successful. It's significant. It's small, but significant, and we're hoping that that significance widens as other provinces are able to report on their data as well. So I highlight this project mainly because I think it shows the direct patient interaction and direct patient outcomes that can benefit from this type of primary care research. But the use of this network for research is quite wide. And so we have studies ranging from the timing of screening for gestational diabetes on fetal and maternal outcomes. So Dr. Piccinini led a study using the data doing that. We have a group in anesthesia currently looking at prescribing of medications for acute and chronic migraine headaches and how family physicians are changing that approach over time. I currently have a medical student working with me that's looking at prescribing and real-world impacts of prescriptions for weight loss, for medications for weight loss, and how that's shifted and changed over the last 4 years. So I hope at this point in the talk, people are excited, for this EMR research, that we really have an opportunity here to expand our knowledge of primary care in Nova Scotia. I'd like to kind of circle back a little bit to some points that Dr. Laverne brought up in her talk, and that is this technology, while a great enabler for research, as you've seen, is also one of the causes of administrative burden and workload within the primary care group. I won't talk in detail about this painting, but this was a self-portrait done not by myself, by a physician in Ontario, highlighting the rapid shift to virtual care over the COVID pandemic. But I actually think it goes beyond that, in that this scenario is very common in the evenings now, on the weekends, in the early mornings, as we interact with the EMR that now comes home with us. It's on our computers, it's somewhat on our phones, and it's ever present. And as we see, it is applying a weight to family medicine. So what do we do about that? So I'm going to shift a little bit and talk about a new technology. I'd like to just ask quickly, for a show of hands, if anyone in the room has interacted with or used AI for any purpose at this point. So a lot of folks have intersected with AI. So you won't be too mad at me then to know that I used AI to help me with this presentation. So, AI can help speed us up a little bit. I wanted an image of a physician caring for a geriatric patient. I put in a simple prompt and got this image within about 10 seconds. So I want to dive into a little bit more deeply to how, some of the risks, I guess, associated with AI and the opportunities that we have. So I'm actually going to back up a slide for a second here. So we have an opportunity, we have a group that just received funding within DFM to look at how we can use AI to improve that administrative burden in the primary care office space. And the tool that's emerged over the last couple of years is something called an AI scribe. And what the scribe does is it's essentially a software that joins us in the room in this interaction between the patient and physician, listens into our conversation, and at the end of that visit generates a chart note that we can move into the EMR. And the early literature says, that this technology can save us up to 50% of our time in charting. It sounds excellent. But I want to talk about some of the risks and some of the real kind of world experience I've had with the technology. So I've had a chance to try it. And we'll use kind of this image as an analogy for how it's worked kind of in practice. So you get a chart note, you have a look at it, and it's not quite right. I mean, you take a closer look, and we realize here Mrs. Smith has 6 fingers, and one of them is kind of headed in the wrong direction. We take another look at this gentleman's EMR, and it looks more like a chalkboard than it does a computer program. I think I'd be a little hesitant to use that. And we look at this anatomical picture in the corner, and the longer you look at this picture, the more bizarre it becomes. Um, and then just a comment on the overall picture itself. So, I asked, for a physician caring for a geriatric patient, and at its default, ChatGPT gave me an image of a Caucasian white male caring for this patient. And it begs the question, is there any kind of bias associated with this image in particular, or are there some underlying biases within the AI program itself? And we know that this is a thing. We know that bias exists in AI, and that bias can be perpetuated, particularly in marginalized, racialized populations. And so it's something that we have to be mindful of as we start to implement these technological solutions. So our group is going to be looking at this. We're going to be engaging with clinicians on how to best implement this type of software. We're also going to be talking to the other person in the room here, the patient, and trying to best engage with them on how to best use this technology while mitigating the potential for bias and the potential for a widening of existing inequities. So I'm going to leave it at that, and thank you all for your time, and hope that as we move forward, we'll be able to report back on harnessing this technology even further. Thank you.
Thank you, Dr. Grandy. Our final speaker this morning brings global expertise to Dalhousie as a distinguished professor and research chair. This is Dr. Kevin Potty, also a graduate of Dalhousie Medical School. His work in health equity and digital transformation is transforming care in vulnerable populations and informing clinical practice guidelines. Please welcome Dr. Potty to the stage.
Thank you. I'm really happy to be part of our family medicine department here in Dalhousie, and I'm really excited to see my colleagues and the research they're doing. Events such as this, to me, are incredibly positive. It leaves me, I guess I have a couple of slides. This is just to remind me where maybe I've come from in terms of my systematic review methods, as well as recognizing that resources will always be limited, and so we really need to make sure we're using the most effective treatments. I'm very actually hopeful to be part of family medicine, and I think, like Matt said, that AI and other digital transformations are going to transform how we can engage more patients. We can be part of education and guidance of more patients, and we can be more effective at treatment and at care. And I believe we have already evidence from the US that these technologies are going to be able to increase our patient populations by 30% because we're going to start practicing differently. So I'm feeling very hopeful that even though our numbers don't look good, I believe we're actually going to be more effective over time. The thing that I'm most excited about these days is a new molecule that you might have heard of, Ozempic. Ozempic and similar molecules, they're not new actually. They've been around for over 10 years. But what's exciting is they thought this would be a good treatment for diabetes. But then when they did the trials for diabetes, they realized that this also helps weight loss with virtually everybody. And then they started looking at the data and they realized there's less strokes, less heart attacks, and then the blood pressure is actually going down. One of my colleagues in Toronto now is using Ozempic as a first-line treatment sometimes for blood pressure in people that are overweight. And then the studies got larger and we started realizing they actually help kidney disease, which is really an important area, and then liver disease. And then, so as again the trials are mounting, we're seeing that they actually are having some hopeful impact on dementia and other neurological diseases. And I think the mental health one is something that really interests me. The molecule operates at different sites, such as the gut, the pancreas, the liver, but also the brain. And the thing that we've been finding is that people don't have the same compulsion to eat they feel freed of this constant decision-making, trying to decide, how do they live and eat healthy. Then they actually have less interest to smoke, less interest to drink, and we're finding less deaths from opioid overdoses. And so I just think that this is a really exciting time. But is Ozempic a miracle drug? I would say yes and no. I think that the reason I say no is that behind the use of Ozempic is a very strong diet and exercise and almost community-linked program. So all of the trials that have used these drugs have also all started with this as the basis. So the group that doesn't get Ozempic has this, and they usually lose 5% of their body weight, for example. And the group with Ozempic uses this as well, plus the medication. And why this is important is that in all of these trials, and there's a lot of trials, it's kind of incredible, that it's looking like only 5% of people will discontinue the Ozempic after 1 year. And the reason this is important is that these medications will need to be used for a longer term. I don't want to underestimate the importance of gastroplasty and other medications, but I think that my message here is that the diet and the exercise program is sometimes not talked about. So they did a recent study in Boston looking at what actually happens, and 50% of people will discontinue Ozempic in the real world after 1 year. And for me, that's what I'm really interested in, because I actually know from my work, which is looking at populations that are already facing the overlapping diabetes and obesity epidemic, which include indigenous populations, to some extent African Nova Scotians, other newcomers coming to Canada. Some of the highest obesity rates are currently in the Middle East, and this is something that people don't realize, as well as people of low income and rural populations. So those people are probably not actually even getting access to the information, let alone access to the drug, let alone access to a culturally appropriate and reasonable diet and exercise program. So I guess this is what I want to work on. I'm working with WHO, as WHO is considering this drug as an essential medication. When this happens, there's a lot of international advocacy to lower the prices, improve affordability, improve access. But I think there's a piece that we're working on with WHO is this culturally appropriate, these diet and exercise programs that cannot be underestimated in terms of importance. Weight Watchers was basically on its way out, with Oprah Winfrey doing so well on Ozempic and finally realizing, I'm going to leave the board of Weight Watchers. But Weight Watchers has realized that they actually now have probably one of the premium programs for people on Ozempic with diet and exercise, and then there's community programs. It's not about individuals. I think it's going to be about communities working together on their diets, on their exercise programs. So now Ozempic has a new program that I think is already really effective. Is this program going to reach our rural population, or are some of our new arriving refugees? So I'm very concerned that we need to find a way, and I think Nova Scotia Health, we can actually be leaders on this. I think we need to kind of learn how to build these programs, make the medications and other treatments more affordable and accessible. And I feel like that, there's a lot of hope. I just came back to Nova Scotia after 25 years in Ontario, and it's incredible to be here again for me, living on the ocean. It's an incredible place. But I was a bit shocked to see that Nova Scotia is a bit of a leader in diabetes at 10%, obesity at 40%, in the maritime provinces. So we have an issue we have to work on here. Our future, I think, is at stake. We need people to be able to look after their families. We need people to be able to work. We need people to live in a healthy manner. And I see that to me is my focus for the next, till I retire, probably. That's what, oops, I did have one more slide. Just sometimes people don't understand what equity means, health equity means. It's not about equality, giving everybody the same thing. It's about giving people what they need to be engaged, educated, and have better impact on their health. And this is kind of what I work on. That's it.
Thank you so much, Dr. Potty, and a round of applause for all of our great speakers today. So hello everyone, my name is Catherine Ewell and I'm the Executive Director of Advancement for the Faculty of Medicine. I am in charge of leading the team that raises some funds to support this great research, so I will put my message in at the end of the program before 9 o'clock. But we are committed to wrapping up at 9, and the most important part of the morning, I almost said evening, I've been up for too long, is that we want to give you a chance to ask some questions of our researchers. So I'd like to invite the researchers to come back on stage and join us on a stool, have a glass of water if you like. And while we're doing that, I'll just give you an opportunity. Think of a question that's burning in your minds. You can pose it to one of these researchers, or you can just pose to the panel in general, and we'll let one or two of them opt into providing an answer. The process we'll follow is please put up your hand if you have a question, and one of our team members will come over with the microphone. And once you have the microphone, we'll have you pose the question so that everyone can hear. All right, who's got a question? Let's see a show of hands for anybody with a question. And if you're feeling a little bit nervous, I've got a few of my own to get us started. So we have one, excellent. Here comes Dana, and we'll get to you in a moment.
Thank you for those very engaging presentations. I just have a question for Dr. Grandy. My experience with the technology as it moves forward over my very long time is that each step transfers administrative burden to the physician away from clerical staff. Like, you know, we went to the EMR and the physicians had to do more and more of the data input. We went to this OCEAN process, which means that the physicians do the clerical work. Is there a way around that, or is there a way to engineer that so that we're not doing the clerical work?
So, okay, I'm live here. Yeah, thanks for the question, Dr. Murray. I think, I don't have a solution for this other than I think the right people need to be engaged at the time of development of these pieces of technology, these pieces of software. And as primary care clinicians, sometimes our voice may be less heard as these processes are kind of being developed and rolled out. So as I hopefully highlighted with the upcoming work around the AI Scribe, I think one of the key factors is engaging clinicians who are going to be using these technologies on a regular basis to ensure that the technology is on the supporter side of relieving administrative burden and workload and not the driver side. And I think as we've seen historically, some of these technologies, while they have great promise, end up landing on the driver side just due to the way those workflows end up rolling out in real time.
Thanks for that great question. We have another question over here.
Yeah, thank you to all the speakers. Really interesting information to hear this morning. This was just sort of a follow-up to that question for Dr. Grandy. You mentioned in your presentation that AI will allow physicians to see up to 30% more patients. So my question is about balance. Many of our physicians are saying, I land in my office at 7 a.m., I'm still there at 7 p.m. They're looking forward to AI to maybe get them home by 6 o'clock and actually have supper with their dinners, whereas on the other side of the system for the those who are looking sort of at the numbers are thinking, yay, we're going to get 30% more patients through, and I know there's a happy medium, but how do we find that?
And So thanks for that question. I'm going to give my response, but then also defer to Dr. Potty. So I think Dr. Potty mentioned the 30% more patients as a result of AI. I agree with you. I think that this technology has the capability to reduce that burden, but I would hope that we would be looking for those reductions not only during clinical time to improve clinical efficiency and see more patients, but to reduce that time spent in the evenings and on the weekends doing these administrative burdens. And I think that that has to be a factor that's looked at, A, when we're reporting on research in this area, and B, when it comes to what is considered a positive outcome of the implementation of this kind of technology. Does it necessarily have to be an increased inpatient volume seen, or can it just be a reduction in workload, both inside that clinical space and outside? I don't know if there's anything you'd like to add there, Kevin.
I think patients have to take more responsibility for their health care, and I think we need to be more in the guidance role. I think that it's very exciting. I think that Nova Scotia Health is giving your blood results in a week and your x-ray results in 2 weeks. I guess I'm coming from the Ottawa area. We've had that for 7 years, and you actually can get your results immediately. And so this is just one example where I feel there's going to be a lot of opportunity to engage people to learn. And when you give people results, the newer programs actually have educational modules, how to understand your pathology results, how to understand your blood results. I personally feel that it's really important that as many people in my practice that can take advantage of this do, because I think that is the shift from doing all of the education to being a guide within a positive world that has good education. And I think certainly we need Nova Scotia Health, which already has a lot of educational modules. We really need to work together. So I see that putting us more in a guide role as opposed to we must educate, we must treat. People probably don't realize that we don't just decide what's wrong and give medicine. We need to have a relationship with the patient. We need to be able to help them understand something that could be very complex. There's a lot of elements that really take a lot of our time, which I believe could be much more efficient if we have people understanding the illnesses better.
Thanks both of you for that great response. Just a quick add to that. I know my colleague from Varian is here today and they are working closely with Nova Scotia Health and our partners, QE2. And I know that there's interface in the cancer treatment world where the cancer patient is following along with real-time results. That's really making a difference in that area of care. We have a next, but we'll keep you in mind there.
Hi, my name is Susan Halliwell from Mentor Clinic. We've been using an AI scribe in Mentor Clinic for several months now. One of the things that I think we're working on and evaluating at the moment is the AI scribe, in addition to collecting information about the visit and creating a summary note, which has saved our practitioners time in their charting and got people home earlier. The other thing it can do is create a summary of that encounter for the patient. So then I think that's really the value, and that's what I've been sort of pushing our team on is you may be using a template for your visit, great, but you still need to use the scribe because then it will create this patient summary. You can give that to the patient or send it electronically afterwards. And now the patient has a record of their visit, because when you talk about patient engagement in their own care, what happens now, they go to this visit, they have to kind of listen in their 5 minutes and take notes or whatever, and you never know, did they hear what you actually said? And so now they can take this home and say, oh yes, I forgot to tell them about this family history or whatever, and next time they come. And it also has a clear list of actions. Oh, here's your responsibility for getting your blood test done or doing whatever. That's a lot of the value in the scribe as well, is what we're finding is that's the patient sort of centered side of it.
Great, thank you for that. Next question. I saw one over here.
Thank you. AI is very interesting, but Dr. Marshall mentioned something that gives me hope also, and that is something that when too quick for me to catch, which is the Master in Physician Assistance. It seems to me that I know a couple of young people I could twist an arm, I think, maybe, if I knew what this program was. But how would this assist the doctor and the process with a person who is between the AI, the doctor, and of course the patient? What is this program you're talking about? Master's grade. Thank you.
Yes, this is a novel program that started at Dalhousie, and it identified.
We need you to be mic'd. Just hang on a second.
Thank you. Yeah, so this is a novel program, I understand, that started at Dalhousie University. There was some identification that there is a role to play to have somebody else in the clinic who can help support the activities of the clinic that has more training. So, I mean, there's lots of you here who are physicians, and you know that there are amazing admin staff who work at the front desk, but there's other roles that people can play that help facilitate the work in the clinic. And so they developed this program that's been running, I think, for, is it 2 years now, I think? At least 1 year, that trains people to work in a clinic where they have some additional skills to offer, which saves time for the family physicians and nurse practitioners and other allied health professionals in the clinic. So I don't know much more than that, but my understanding is that it's been a very welcomed program.
Next, thanks so much, and you can talk to Dr. Anderson a little bit about that. Another couple of questions in the middle there.
Thanks. This is a question for Dr. Marshall and Dr. Laverne. I'm Naba, I'm a general internist. So I do a lot of inpatient work, and we get a lot of complexity coming through the door of the hospital, and many patients are unattached. And we know that the system isn't really set up in order to equitably match patients with their complexity and their needs with primary care systems. So I was wondering, do you have any thoughts about how we can actually incentivize primary care to care for complexity?
Sure, I can speak to that, and then you can add on since you've done work in the area. So we have quite an established literature around financial incentives related to complexity, and it shows not a whole lot of effect. It's really important to pay people fairly for their time, but where we've looked at both within Nova Scotia and in other jurisdictions, an added payment tied to complexity alone is not going to make the difference if you're over capacity and under supported already. So while there's a role for payment and there's a role for payment systems that don't get in the way of managing complexity and providing equitable care, I think all of the evidence points that that has to run in support of teams that are equipped to manage it as well. And so we keep saying teams, but that includes people with expertise to interface with home care and the supports needed to manage people's day-to-day activities, as you would well know. That includes teams that have depth of expertise in care of the elderly, and that's an area of growing training. And it includes teams where there is space for people to come together for a game plan around people with complexity defined in different ways. And so I think we're getting there, and there's, again, really exciting models, but that piece of really supporting teamwork and not just groups of people is not the splashiest policy reform, but I think it's where we really need a lot of attention to be able to pull those pieces together and work beyond just a one-time payment that says, now you're paid for complexity. You'd add?
Yeah, I think that was an excellent summary of where the challenges are, and I think there's also some solutions around this. I think there's some amazing programs that have been developed. I think about the Health Authority and what they've been doing to try and create programs, for example, for people with cardiac issues, and they can go for these. They now have them designed for, there's one specifically for women and separate from men, and there's opportunities for people to get education and find support in those environments and to learn how to do things safely that can be really beneficial. And I think those types types of programs. There's all kinds of programs, actually, that Health Authority runs. I remember going on the website and just being like, oh my God, I think I want to sign up for all of these. They can be so helpful. So I think there's a lot of room to improve. I also think I know there's some physicians here that I've worked with, Melissa Andrew in particular, around how do we identify those folks who come into Emerge who need that extra level of care, and then how do we help support them in different ways and get them connected to the right people, which is really hard to do when you're trying to just deal with a specific acute situation at the time. So I think there are opportunities that we could be doing better. It's just challenging with trying to cope with the system and it being somewhat overloaded at the moment.
And I just add one piece. I think sometimes we say complexity, and what we mean is poverty, and what we mean are people without the basic resources that they need to get by. And so we can medicalize that and frame that as complexity within care, but we can also turn our attention to fraying social systems, to housing, to the supports people actually need, rather than patchwork within primary care or within healthcare.
Great, thank you. I see a few more questions, and we've got one ready here.
Good morning. John Ross, thank you very much. So all four of you have stimulated 100 hours worth of questions and comments, which I won't do right now. But I kind of feel like I've stepped into heaven here just hearing all these topics. So we started the Mentor Clinic, which is a primary care interprofessional, truly collaborative project, which has been going for about a year and 15 months now. It is the way of the future, team-based, truly collaborative care, but there are so many learnings, and so the research you're doing and that of others is going to be super, super useful for us, because we are kind of learning as we go, but I'm both optimistic and hopeful here in Nova Scotia with all our challenges and all the media negativity that we see, that we've got a lot of good people that are doing the right stuff. I can't remember, I think it might have been Dr. Emily that pointed out the who's in charge piece of this thing. I think that's one problem that we still currently have, is don't actually have a visionary primary care leader in this province yet, and we still kind of need that. So anyway, it's just a more comment, and thank you so much for all four of you, because you've really got me excited even more.
Do we have any other questions?
Yeah, two more.
Thank you. That was great. Makes me very proud to be a member of the department, so thank you. And just as a comment, my vet actually sends me summaries of my pet's visit afterwards, so it can be done. I know there's a lot of lobbying going on right now with federal government about disability tax credit forms, and the figure I read was the time it takes for family physicians to complete that form is the equivalent of 1 million visits per year. So I know the College of Family Physicians of Canada is lobbying for that, but my question is this. Third-party insurance forms have been the scourge of family practice I've been in practice for almost 35 years, and that's been an issue. Has there been any look at putting the pressure back on lawyers, insurance companies, to get their own consultants to do these forms? Because the time it takes to do them, and the expectation and the fact that, yes, you can bill the patient. Most of these patients, if they're doing these forms, they can't afford them. So we all do this work for free, and it just seems to be a given. We just go, oh, these forms. But is there any look at putting it back on the private sector and say, this is your issue. You get your own consultants. You work with your client to have someone review your chart. Has there been any work on that?
I can speak to it to some. Applies to that. This is one of those challenging areas that is no one's job, right? It falls outside of our publicly funded health system. So it would require coordinated regulatory efforts to make that a responsibility that is not borne within primary care. There has been increased advocacy, and I think we might be seeing a tipping point where asking for publicly paid physicians' time to actively gatekeep private resources for profit is viewed as unacceptable. And I think it's part of a broader shift that we could question in terms of when are family physicians being asked to gatekeep resources to save someone else's bottom line rather than supported to do their best work for patients. So I think I'm glad you raise it. It's something that I'm hearing discussed more, and I hope we're maybe at a tipping point where that's something that we can really actively challenge as a profession and as a department.
Yeah, I'm seeing an opportunity to collaborate on something maybe we could publish as an op-ed of some sort.
That sounds like a great plan. We're going to take one more question, but don't worry. If you have a question that didn't get answered, I think our researchers will be around for a few minutes after the event. But just to get us wrapped up by 9, we'll take one more question, and then you could maybe meet the researchers up at the front if you still have a remaining question.
Hi. This is also a question for Dr. Laverne. It kind of got spoken to in a comment, but I was just wondering about your research and whether there's been any work into how it's going to apply to collaboration with interprofessional care. I mean, with new primary care pharmacies popping up in Nova Scotia and the increasing role of our physician assistants and nurse practitioners, how that's going to apply with the research that you're doing.
Sure. So, I mean, again, there's so much activity. There's lots of these great models, but I think a common challenge carries across them, and that is fundamental to primary care is continuity. It's following people over time through relationships and through flow of information. And if we're not investing in infrastructure that supports that, we're not getting it right. And so that is the basic infrastructure that can support teamwork. And then layered onto that, it's I am nerdy about paperwork, you guys, and I'm nerdy about administrative capacity in primary care. That people who have the expertise to put in place new technology systems to support process change are so desperately needed. And I think that's an area where we're doing some work just on the mechanics of practice management, where we'd love to learn from the Mentor Clinic and other models where they're really working these things out, and then figure out how we can use that capacity to better stitch together these different access points so people aren't just getting seen, but they're getting followed over time and balls aren't being dropped.
That's great, thank you.
And chat more about the specific projects.
Hop up to the front afterwards for any additional conversations there. So thank you so much for your very thoughtful questions, and of course to our speakers for their very insightful responses. One more round of applause for the speakers. It's clear that the research happening here at the Faculty of Medicine is making a meaningful impact on family medicine, not only in our region, but also nationally and internationally. Now, if you would like to recap on what happened today, or you were thinking of taking notes but didn't bring a pen, don't worry. We did videotape the session today, and watch your emails in the following couple of days, as we will be sending out some additional information, the video, as well as a way for you to potentially reconnect and ask more questions, or even consider supporting some of the research in this area. Be sure, if you haven't done so in the past, that you sign up to get your Remedy magazine. This is our twice-a-year magazine featuring all of the great research happening at Dalhousie, and it is still in print, so everything old is new again, right? People love the print copy. Digital available if you prefer. Also, our next Breakthrough Breakfast will be happening on March the 11th, and it will be on brain health. So if you enjoyed this format and you would like to hear more about the exciting research happening at Dalhousie, please make sure to join us once again. If you can indulge me just a moment, as the team that is responsible for raising resources to support this faculty, I do want to pay a special thank you once again to our sponsors. Such an important contribution that they make in enabling us to share these events with the public and with our stakeholders. So a big thank you to Shanex, who's been with us for the entire series. This is their 4th event as gold sponsor. A big round of applause for Shanex. And some repeat bronze sponsors, Lawtons, the New Brunswick Medical Society, and the QE2 Foundation. And if I can say a special word about the QE2 Foundation, these are our fundraising partners. The QE2 and DAL have long been working in collaboration, both in raising donor support and in the delivery of excellent education and healthcare. The QE2 is advancing healthcare, ensuring that patients and families have access to the most advanced treatment available. So, of course, we are both eager to engage you and attract your support if this is an area of interest. Thank you to the QE2. And now I will turn things back over to Dr. Anderson, who will close out this morning's event. Thank you again for your participation, and please don't hesitate to connect with us.
So I just want to, again, thank our speakers, thank our sponsors. Thank you for coming, another exciting breakthrough breakfast. Again, if you do have further questions for our speakers, just come on down to the front and they'd be happy to chat with you. Great to see everyone. Look forward to seeing you at our next breakthrough breakfast on brain health in March, and enjoy the rest of your day. Bye, everyone.